This information is for educational purposes and does not constitute medical advice. Speak to your medical professional before making any changes to your care.
Welcome back to the Lichen Sclerosus Support Network's channel, where we bring you all of the evidence-based information and support so that you can live with LS and thrive. And today I'm so excited because I'm bringing back a fan favorite, my favorite, and we are going to be touching on a conversation that started 4 years ago now, and I'm really excited, always excited to talk to her. We're going to talk to Dr. Jill Krapf, who is not only an amazing doctor, vulvovaginal specialist, I say one of the top doctors in lichen sclerosus in the nation. She is an author. She is a researcher. And last but not least, or not last because she's an educator and a whole bunch of other things, but she is also our Ride or Die first ever medical advisory board member, and she has been riding with us ever since. And welcome, Dr. Krapf. I'm so happy to have you here.
I'm always happy to talk to you, always.
Thank you. So, I kind of alluded to it, but we're going to be talking about how to use your steroids. Now, this conversation started 4 years ago now, even before the nonprofit was started. We started on the Lichen Sclerosus podcast, and that episode has blown up. It is the biggest episode of the podcast. And when we started, there was like an information desert. We had nothing except for like the medical stuff on like the Mayo Clinic. And it was really hard to understand. And it did not include the nuances and the information that you gave us when we had that conversation. It really was an explosion in the LS community because we finally had answers. Tell us how you felt like back then as a provider.
Yes, so there was really hardly any guidance. Most doctors didn't even know about lichen sclerosus, even gynecologists, because they didn't see it, right? But actually, they were seeing it. They just didn't know. And there's a lot of reasons for that, right? It's a diagnosis, it's a condition caught between two medical specialties. But the other part of this is in our textbooks, we read that this condition only happened after menopause or sometimes in kids. And so there was a large group of the population that we had no idea could even get lichen sclerosus, or if they got it, then they were very rare, which we know is not true. And the research that subsequently happened, some of it was actually my research, really showed that the presentation, the clinical presentation, was very different in these younger women in their 20s, 30s, 40s, even 50s than it could be in after menopause or even in children. And so as we learned more about this, we had to change a little bit how we approach this condition, and our patients informed us of the differences as well. And I have to say, as we're identifying it, as the awareness increases, more people are coming forward and we are diagnosing it so much now, right?
Wow.
That it may not even be as rare as we once thought. In fact, it may not even be a rare condition, right?
Yeah.
And so, along with that came the idea that everyone is obviously an individual, but our diagnosis changed, our counseling has changed, and our treatment recommendations have become a little bit more subtle, right? Have accounted for the subtleties and the intricacies and the individuality of everybody's lichen sclerosus presentation, depending upon where their condition is, when it's being diagnosed, their age, their hormone status, their function, whatever that might look like. So, really, these little intricacies have come in. And back when we started 4 years ago, we didn't have the luxury of even that. It was
Right.
what is lichen sclerosis? How do we even find a diagnosis? How do we even approach starting a treatment regimen? And because people didn't have that, they were coming in much more severe
Mm,
than they may come in now, right? Because these resources were just they just weren't available.
yeah, absolutely. I find that exactly what you said, they're getting diagnosed sooner. A lot of the people that are coming in into the community now are like, I got a diagnosis after 6 months, or I got a diagnosis right away, which is amazing. We love to hear that. Versus when we first started, it took years,
Years.
years. So very excited about the change. Very excited to talk to you about what you guys have learned, the nuances that, are now being implemented from all the information that we've gathered over the last 4 years on how do we treat what you're seeing now, and understanding, like, Jacqueline, my beautiful, beautiful partner in this space, says that science is always evolving. So what do we know for now? And who knows, we'll do this in 4 years and we might have something completely different
I
or a
hope
little
we
bit more nuanced, right?
I
Yeah,
hope
new
I hope
treatments,
we
new
do
things,
because
a
that's
cure.
that's how things work. Exactly. It would be so nice. And there's definitely things in the works that are more and more targeted, that are very exciting. But I think that we have to know where we came from to understand where we are now.
Sure.
And so a lot of the guidance was based on the European guidelines. So there were international guidelines that were put out on lichen sclerosis, and these are quite old at this point. Not much has changed, I would say, except for understanding the subtleties and intricacies of it. But all we had to go on initially was a pretty specific treatment regimen, right?
Mhm.
So the idea that you would apply a ultra potent topical steroid, the one that was in most of the studies is clobetasol, either a cream or an ointment. Back then, we didn't really know the difference between the two. Now we understand a little bit more. But you would apply that, once a day or even twice a day for 4 weeks, and then every other day for 4 weeks, and then down to a twice a week maintenance regimen. Now, the guidance is going to change depending on if you see a gynecologist or if you see a dermatologist, because the teaching is a little bit different in different fields. The other thing that I see is that oftentimes people are put on a topical steroid twice a day initially, which, if you're using a cream, that is probably okay. But if you're using an ointment and you're soaking prior, that might be too much, right? So there's a lot of different parts of this, right? And so what we need to think about is that there's actually room to move. So that idea of once a day for 4 weeks, every other day for 4 weeks, and then twice a week, that is for someone who is active, who has active lichen sclerosis. So thickening of the skin causing itch. And even for somebody who is active, that might not be exactly their regimen. If they are very severe, they may need a topical steroid for 6 weeks daily, and then every other day for 6 weeks. And then, if they're not quite as severe but still active, they might need it every day for 2 weeks, and then every other day for 2 weeks. So really, the subtlety is that, if somebody is active, meaning they have itch, they have thickened patches. And this is typically determined by a doctor taking a look with lighting and magnification, whether that be a gynecologist or a dermatologist or anyone who is trained in lichen sclerosis, usually makes that determination if the condition is active or what we call in remission, which means that the inflammation has quieted down, right?
Mhm.
But remember, all of these treatment regimens that were in the guidelines were for active lichen sclerosis.
Right.
And now we're seeing people who come in and maybe they're not quite, they're very, very subtly active, or maybe they're already in remission because they've used a topical steroid in one way or another, whether it's, optimal or not. And people are presenting in different ways. And that means that their treatment regimen may be slightly different than what we saw as very prescriptive in the guidelines. We now know that it has to be individualized and it varies. And we realize that access is an issue. So even people, and we know from the support groups that people will just try a regimen because their doctor gives them no instruction when they give them the clobetasol or the topical steroid, and they'll try a regimen, but it's important to listen to your body,
Mhm.
right? And so if things seem to be responding in 2 weeks instead of four, or if it's not responding in 4 weeks or what have you, there has to be variation and allowance because not everyone is the same.
Absolutely. I even myself, when I first started this treatment plan, I had itching before, and so I started, but I was also using the steroid as needed intermittently for years before I actually started doing the once a day, every other day, and then tapering down. And when I got to the beginning of the 4th week, I started feeling like a heat after I applied the steroid, which was odd because I had never felt that before. And so when I went the next day and I felt that heat again, I took it as my body saying, "Okay, we don't need as much steroid anymore. You can taper down." And so I did taper down to every other day, and I didn't have that heat anymore. So again, like you said, it's so important. I say it all the time. The most important thing is listening to your body. Because I think for a lot of people too, when they come to the support groups and they ask me this question, and I let them know your symptoms have gone away and you're feeling good, and you feel like, okay, I want to taper down, and you taper down and your symptoms start picking back up, then that's your body kind of letting you know, hey, we need to go on a little longer. And so try it for another week, and then you can try to taper down again. I always tell them a doctor can see 1,000 patients, but they're not in your individual body. So
Exactly. And this is the perfect example, right? Now, as a specialist, I'm pretty good at predicting whether someone needs 1 week, 2 weeks, 3 weeks, 4 weeks, 5 weeks, or 6 weeks of whatever dosing regimen before they go down to the next. I mean, that's a part of my job, right? But I'm good at that because I'm a specialist and I see
mhm,
so much lichen sclerosus. But even so, you have to listen to your body because that that might not be exactly what your body needs, or you may see a practitioner that doesn't have quite as much experience who is going to be a little bit more prescriptive, but no, and you don't want to stick to something or power through something when it might not be exactly what you need. And so because of these subtleties, we have decided to change the guidance to allow for this variation from Lichen Sclerosus Support Network, just to acknowledge that it could be when you're active. Again, this is all active. When you're active, it could be a regimen of 2 weeks, 4 weeks, 6 weeks, or anywhere in between. And that is completely fine as far as your step down regimen to get to a maintenance regimen. And that brings us to the idea of making the topical steroid the most effective possible, which comes to the idea of soaking and rubbing. Now, there's nuances in this as well, because remember where we came from. Where we came from is that no one knew about this condition. People were presenting in very severe states because they weren't getting the care or the guidance they needed, that they had a lot of thickening when they were presenting. And to make the steroid more effective, those patients in their states needed to soak prior to allow for the steroid to penetrate. And we were finding that patients were just putting the steroid on like icing on a cake on their skin. And with the disease process, the inflammation in that basement membrane in the bottom layer, it changes the way that the skin cells regenerate on the layers above. So you have a thickened layer in the middle, but you have a thinned out layer on the top. This is just a part of the process of lichen sclerosus within the skin. And so if you're just putting the topical steroid like an icing on the cake on the top, it's just thinning out the already thinned out layer. It's not getting through that thick middle, and it's certainly not enough is getting to the basement where all that inflammation is. And so soaking and rubbing in sufficiently was a way to facilitate application in a more effective way for those patients that were so active and so severe. Now, the issue is that, things have changed, right? People are coming in with different presentations and different levels of severity. And, for someone who, for example, is not active, who's in remission, they don't have that thickening in the middle. They might not have itch, right? And so they don't have to necessarily soak prior to application of their steroid. Now, even within that advice, doctors are going to disagree with me. There's certain gynecologists that will say that everyone has to soak no matter what. And then there's certain dermatologists that are going to say no one should soak ever, right? So I think that the answer probably lies in the middle, right? I think that if there is thickening of the skin, it would be helpful to soak, and this is temporary until you get into remission, and then you can apply after a warm shower. But there's always going to be differing opinions and disagreement. This is why it's so important to listen to your body. I think that a shower prior is helpful because it warms the skin and it softens the skin, which is going to help an ointment melt a little bit and you'll be able to rub it in a bit more efficiently. I mean, this just makes sense, right? From a logistics standpoint. And then with rubbing, the idea was we were just trying to counteract, the bad advice that was given to people to just slather this on. So the idea with rubbing was kind of an overcorrect because people were coming in so severe. But with rubbing, and the time limit that was attached to that was just to emphasize a point, right? That you don't just slather this on and, set it and forget it, you're good. You really do need to make sure that it's sufficiently absorbed. Now, does that take 120 seconds, 90 seconds, 60 seconds, 45 seconds? I mean, who knows, right? It depends on how, if you apply it after a warm shower or soaking, or how severe the condition is, how thick the skin is, what the surface area that you're covering. Like if you have a very small area versus the entire vulva and the entire anal area, obviously that's going to take a little more time than if you have just a small area around the clitoral area or what have you. So I don't always give time limits to people unless they need something very, discreet or very prescriptive. And even then, it's not going to be the same for everyone. What I now tell patients is rub the ointment in until it's sufficiently absorbed. And I believe people understand that. So we're really trying to move away from, a one size fits all, very prescriptive, and move toward what makes sense for my body, what makes sense for my condition where it is, and what makes sense may be different from when I first presented to now when my condition is under control and I'm in maintenance phase. These things may evolve in the same person, and they're certainly going to be different from one individual to another.
Absolutely. Which, again, like you said, makes sense because the skin is healing. The skin, when we start off and we're active, you have the high levels of inflammation, which are changing the different things that are going on underneath the skin that are showing up as our signs and symptoms. But then as we're treating and the skin is healing, then now we're dealing with healthy skin. So we're not going to treat the healthy skin the same way that we're going to treat the skin that is actively being harmed by the condition. I will say again, personal story, I never soaked. I always am a shower person. I said that in our original episode. I'm not a soaker. I'm a hot shower person. And I've been in remission at this point 3 years come this last February. So going on 3.5 years. And I think, like you said, for me, I always do it after a shower. And it to me, it makes sense because I'm opening up those pores. I'm making my skin inviting to draw in the ointment and so that it can be optimized, right? And as far as rubbing in, I like to use the analogy of when you use lotion. You don't just put the lotion on your skin and walk away and you have all, white lotion or whatever color your lotion is just hanging out on your arm. No, you rub it in until it's absorbed into the skin. And so same difference with our ointment. We just want to make sure that it's not just laying on the skin because it's not being optimized. We want to rub it into the skin so we can get it deeper into where it needs to go so that it can make the most potent for us.
Exactly. I always say that topical steroids are a tool, and tools can be used in different ways. There's positive ways, there's negative ways, and there's everything in between. And, as our research evolves and our clinical practice evolves, we're going to have hopefully more focused and better tools at our disposal. But there's always going to be, even if we had an optimal tool, there is always an appropriate way to use something, and then there's less effective ways to use things. So I think the biggest gift that we can give people with lichen sclerosus is really teaching about the condition and what's happening within the skin, and then really just using honestly common sense with application and thinking, okay, well, everyone is an individual. We have to see what level the condition is, how much thickening, how much inflammation, how are we going to make this work in your life? For example, for people who don't or are not able to soak or are just straight up with me and say, Dr. Krapf, I'm just not going to soak. I'm not a soaker. And I said, that's fine. We have different tricks. So, what I tell patients who don't want to soak and they're very active and they need that element, right, which is not everyone, but if you do need that element, I have them do the wet towel trick, which is basically you take a hand towel in the shower with you, you saturate that hand towel with water, you put it around like a sumo wrestler diaper, and then you wash your hair while it's sitting there, right? And so we come up with a solution that makes sense. And that's temporary, right? We don't have to do that forever. We do that until the skin starts to regenerate and heal in a healthy way. And then we don't have to do that anymore. So I think that there's lots of ways to do that. And, the reason that we're having such a discussion about the subtleties is because there can be harm that can come from overuse or improper use of a steroid. And that doesn't just mean not using it enough, right? Or not using it. It means, you could use it too much or you could go overboard or you could, we never want soaking or rubbing or dosing to be a barrier to care either. We don't want someone to say, well, I can't soak, so I can't apply my steroid today. No, it doesn't work like that, right? We need to find ways that are going to work for you. And it's also not all or nothing, right? If you skip a dose one time, if you don't soak prior, if whatever it might be, it's not, we're talking long term here. We're talking, we're not talking a one off. So we really don't want to create barriers to care. And then with rubbing, we don't want to, have that be like a scratching session, right? For someone who's super active. We don't want to give them, we don't want to create an itch, scratch, itch cycle on top of their lichen sclerosus because they're, following, information that may not be optimal for them.
Agreed. Agreed. I think one other thing a lot of people have questions about, and since we are replacing that other video with this new update, I think it's important for us to touch on how much of the ointment are we using. Now, I know in the past I've always directed, again, coming from the British Association of Dermatology's guidelines, like for no more than a fingertip, but you want to use the least amount that you need. For most people, starting with like half a fingertip. I know you were saying like pea size amount, but what I hear a lot from the community is what kind of pea? What do you mean by a pea size amount? So I think like the fingertip is a little bit easier for people to understand. So what kind of nuances are we talking about there?
Exactly. So a pea size, a true pea is usually about 1/3 of a fingertip, but it depends on how large your fingertip is. So what I've found, I'm a pretty petite individual. I'm kind of short and small. So I've been looking at my patients and say, "Oh, show me your fingertip." I found that my pea size is half of a fingertip, but it's no one else's. Apparently, I'm child size because and you've seen me in person, so you know. But for most people, it's a 1/3 of their fingertip is going to equal 0.33 grams, which is typically what we recommend. But it also depends on the surface area that you're applying. So it depends on that. I would say if you're working with half of a fingertip to a third of a fingertip, you're probably in the right zone. But that might be for the vulva and then a separate area of that amount for the perianal area, perhaps, depending on your condition. As far as like a full fingertip, unless you're talking about the front and the back, that usually tends to be a little on the high side. But again, it depends on your presentation. So if we really want to go in the middle, it would probably be a half fingertip, or if we want to err on the side of caution, it's going to be about a third of a fingertip, and your pea-sized amount is going to be more a third of a fingertip.
Okay. And does that, also, like, decrease with, like, getting better with as the healthier you get, or does it stay the same?
It typically stays the same unless you're starting with more. So our goal is to get to that 1/3 of a fingertip or that pea-sized amount. And when we say pea, I always say, "Oh, it's a garden pea, not a lima bean."
Okay. Yeah, exactly. There's so many different size peas. Okay.
That being said, I do have some patients that are rightfully very anxious, right?
Mhm.
And they really want the intricacies of, okay, is it exactly this big? Is it exact? And the reality is that if you put a little bit more or a little bit less day to day, as long as it averages out as that amount, it really doesn't matter too much. We just wanna make sure that you're not smothering it on, and we also wanna make sure you're not using, like, a microscopic pin dot, right?
Right.
So, as long as we're in the ballpark of what we're discussing, it's completely fine. There is a bit of cushion around these recommendations, that you don't have to be exact, exact, exact. And remember, let's go back to just the thought process of why we're doing what we're doing. Being, prescriptions and being prescriptive is very helpful when we're first starting and when people need a lot of guidance. But, as you live with this condition and as you have more life experience with it, you realize that there's subtleties, there's gray areas, there's intricacies, and there's how your body responds, right? And so we have to honor that part of it as well.
Yeah. Yeah. Our another recommendation is do what you're gonna keep doing, right? You don't wanna make it so that you're, like, dreading, "Ugh, I gotta go put on the steroid." No, it's just like brushing your teeth, it just becomes part of your routine, and if you can make it enjoyable, that's even better, right? So, yeah, the goal is to help you live and thrive with this condition, not that you feel like you have this collar around your neck that, I can't go on vacation because I can't soak because where I'm going doesn't have a tub. We don't want that. We want you to love living, right? And that's the whole point. Don't let LS control your life.
Exactly. And I think that, giving ourselves positive affirmations as we're applying this, thinking about visually how our skin is regenerating and how the inflammation is being suppressed. I think those things are really helpful. I also think that, it's important. I joke with my patients, congratulations, now you have a high maintenance vagina, right? To find that
Vulva.
a vulva, yeah,
Vulva.
high maintenance vulva. Right, absolutely. But I think we do need to have like a little bit of humor in here because if we don't laugh, we're going to cry. And there has to be ways that we can, you know, frame this for ourselves where, okay, yes, I do brush my teeth twice a day. Look at the effort that I put in my skincare routine.
Mhm.
I just have a high maintenance vulva, and that's what I'm going to do. That's what I need to do here. And it actually is going to pay off because I'm going to be healthy and happy and functional in this area. But we never want anything to be an added barrier. So everything that we can do to make things easier, to take a little bit of the stress away, but still providing the basic building blocks of a treatment regimen is always what we strive for.
Absolutely. And last thing, when we're talking about applying our steroid that we always get questioned on is, where do we apply? Now, I know there's two camps because I've talked to a lot of doctors, and there's the doctors who say only apply where you have signs and symptoms. And then there's the other side that says, you can apply it to the whole vulva. And then the anus is a whole different separate thing. So I kinda know where you stand on this, but I want you to say your recommendations.
Yes, so there's always going to be variation. However, I typically recommend applying to where lichen sclerosis is or was active, right? Which I can tell based on the exam, based on hypopigmentation, meaning whitening, but I can also tell based on scar pattern, so any scarring that has occurred. And so when people ask me where to apply, I find that very tricky because I can't tell them unless I've evaluated them and have done an exam. But in general, lichen sclerosis is going to affect the periclitoral area, the labia majora inward from the hair bearing area. So the downslope of the labia minora that go towards the labia, I'm sorry, the downslope of the labia majora that go towards the labia minora. And labia minora may be completely resorbed. So they may be at one with the labia majora, and then typically the perineum as well. But this is where we really need to have an evaluation with a medical professional so we can review exactly how and where to put the topical. And then when it comes to the perianal area, not everyone has perianal involvement. And then there are people that just have perianal involvement and have no vulvar involvement whatsoever. I mean, it's less common, but I see it. And so this part is very much individualized. But I would say anywhere that there are changes, either to the anatomy, any whiteness, even if it's subtle. Obviously, active areas are easier to assign, but this is really where it comes down to seeing a medical provider and getting the guidance that you need to apply it in the right way for you.
Yeah, we always advise follow your provider's treatment plan. They should be looking at your vulva, giving you an individualized treatment plan on where to apply, how often to apply, all of those things. But like we said earlier, unfortunately, until we get our provider continuous education program out there and start helping more providers know exactly what to do, we do have to listen to our body. We have to take some control and use the tools that we have to the best of our ability.
So we have to use our tools in the best way possible. And yes, there in the past there was zero guidance, no guidance. Some guidance is better than no guidance, but we have evolved from even there and we demand more. So we are in a space now where we're not just settling for some guidance is better than no guidance. We're to the level of this is individual guidance, right? And bring these questions to your practitioner, bring them to your provider. Show me where my lichen sclerosus is located. Show me with a mirror. Please tell me I should be applying the topical steroid. How should I be applying it? Can we look at a picture? This is what I do with my patients. I have a vulvoscope, which is a microscope with lighting and magnification connected to a TV screen. And we look together. And then I also have a mirror. And then I just got a selfie mirror. It basically is a little round mirror on a selfie stick. And we go over everything. And then afterwards, when everyone has their pants on, because you remember things better with your pants on, we go over pictures we mark them up and people take notes and they draw pictures. It's like they map it out like like we're back in school. But that's what you have to do because I never want anyone to leave my office feeling like they don't know exactly what they're doing. And for me, I'm able to give them that individualized treatment plan, very specific, all questions answered. But most people are not going to have that type of access, but you can bring those questions to your provider and get at least, some of those questions answered so you're not doing as much on your own.
Thank you for that. Things are always evolving. Where we started 4 years ago is not where we are now, and look at all the progress we've done in relatively a short amount of time. And so where we're gonna be in the next 4 or 5 years, I'm really excited. I know there's treatments being looked at. I know more research needs to be done, but I'm also excited in the amount of research that is being done now versus at least when I started 4 or 5 years ago. So thank you for heading the way. I know you and everyone at the Center for Vulvovaginal Disorders is all about research. You guys are all about, helping your patients and helping us to get those answers. And I've met so many new and upcoming students who are entering into this space and are excited and are like, I didn't even know this was a thing. But because of you and people like Dr. Moscar, Dr. Foster, who are creating these spaces for these young people to come up and say, yes, this is a thing, just very appreciative because together we are definitely changing the difference of sclerosis care for the future.
And we could not do it without the patients who participate in these studies and the patients that share their personal stories and are so brave and so courageous. We could not do it. We have to work together on this. This is not going to be solved by researchers alone. This is
Mhm.
not going to be solved by clinicians alone. This is not going to be solved by patients alone. We all have to work together and we really need the funding. We need the interest of the companies that are willing to put resources behind finding better and better treatments for this. And then we need the awareness to even get on the radar to do the things that we need to do to get better resources and better options of treatment for patients. So I think one of the strengths that I see now, especially with social media and with Lichen Sclerosus Support Network, is that we are working together.
Yeah.
We're finally working all together, and there's a beauty in that. And so it's one of the things that I love most about what I do is the collaboration and the genuine curiosity and the moving towards a greater goal, and we're all invested.
Yes, absolutely. It takes a community, it takes a team, however you wanna phrase it, but we are absolutely have to all work together. So, Dr. Krapf, if someone wants to reach out to you, if you're watching on YouTube, Dr. Krapf is on Instagram. She is on Facebook. Can find her links in the description below. If someone wants to work with you in Tampa, so Dr. Krapf has an amazing office in Tampa, Florida. You can book with her at appointments at jillkrapfmd.com, and that's JILLKRAPFMD. Again, that will be in the description. Thank you so much.
I feel very grateful to be able to have these conversations. I feel very grateful to report that we have evolved so 4 years that we're even having conversations that are, this nitty-gritty. I think that's best. We want to keep up the support, keep up the community, and I just think it's a wonderful place that we are. I can't wait to see where we will be.
Agreed. Thank you.